So it's a great pleasure to talk to Professor Andreas Baumbach, Professor of Interventional Cardiology at the Barts Heart Centre in London. And Professor Baumbach did a nice a live case at the EuroPCR. It was managing a patient with STEMI and bystander disease in the pandemic. That was the title of the presentation. And you used there, Andreas, the QFR on the RCA, on the LAD, also used OCT. And maybe you can describe a little bit where you found particularly the QFR useful, where you used it, possible implications, and also at the end, where you also, I believe, did the post-PCI QFR with great results. So I would like to ask you to describe the case for us.
Yes. So this was thank you, Hans, and thanks for the opportunity to talk a little bit about this case, which is still available online, by the way. This was a typical STEMI case to start with, a right coronary artery that was occluded and was opened up by one of our colleagues some weeks back. And then the patient represented for a staged procedure. Now, we made it an example of how QFR can really be very, very helpful to identify bystander disease. We didn't do it in the original practical case, but it is in my eyes, a very important practical application of QFR, because once you've done the target vessel, in this case, big RCA, it took a while to open it up. You don't want to go ahead and instrument, put a pressure wire down the other side in the same setting, whereas doing an angiogram is part of the normal procedure. So you might as well get your functional information there and then. So in this case, we did several things with the QFR. We studied the original target vessel, the right coronary artery, because they had to leave some residual lesion in the proximal part of the vessel. Mm-hmm. They also had some slow flow, and it was a difficult procedure for them. So we did a QFR analysis of this vessel and found it was perfectly all right. And there was absolutely no need to add any procedure to this vessel. And then we moved over to the second target of the day, which was a rather complex tandem LAD stenosis with involvement of three actually diagonal branches. Difficult to assess on the angiogram, and we did the QFR, which supported the view that it is flow limiting, and then went ahead and did the procedure itself. We did with OCT guidance because of the complex nature of the disease.
Yeah, that indeed, I have the numbers here also. The LAD was 0.71 at the beginning.
Yes.
And that is, of course, why you decided to do the OCT and plan the procedure with a couple of stents, I believe, if I remember well. Yep. And also there, I think the end result, you did also a post-PCI, I think, which came out very nicely.
Yes.
I think that was, yeah, please.
Go ahead, please.
That was 0.96 after the procedure, so a great result. I think anatomically, as well as what you did with the OCT, as well as with the QFR.
Yeah. So there's, of course, the interesting aspect that we didn't take long time to discuss, but we also looked at the option of just placing one stent instead of two, just treating one of the tandem lesions. And QFR gives you the opportunity to simulate. So what if I put a stent into this one lesion? What functional limitation will be left? We did that. We would have gotten away with a residual of 0.85, I think. But overall, the decision was made that it would be a better outcome if you wish, it would look better as well. But probably the right outcome would be to put, to stent the whole segment and make it a really good visual and functional result with numbers you just mentioned.
Yeah. And I think in the end it was still quite a challenging case with the multiple stents that had to be placed. Of course, you did the OCT, where you also found diameter values, sizing for the stents, and the placement, proper placement of the stent. So it was not a real easy case, I think.
No, it was, it had its difficulties, but we had OCT analysis. I thought it was quite impressive that the QFR worked without any problem, despite the number of side branches we had, and despite the distorted geometry of this lesion.
Yeah.
So in the end, we got there.
Yeah. Now, for this particular purpose, I mean, you have not done much work with that with the IMR, but we provided you also with an early version of the angio-based IMR. So where, of course, the additional input for that is aortic pressure, and then you do your QFR, and at the end of the calculation, basically you have the results available at the same time. It doesn't cost much extra. And in this case, the IMR was 28, which is maybe at the threshold. And usually we say 25 or so is a threshold. Yeah. So what did this? I mean, this was an early impression for you. What do you think of that?
Yeah, we've done studies with looking into IMR and the correlation to MRI results to the microvascular obstruction in acute STEMIs before. So the IMR gives you an insight into the microcirculation. It basically, well, it tells you in the acute phase how bad the impact on the microcirculation is and how big an microvascular obstruction you can and hence infarct size you can expect. So you can single out patients at higher risk. That's the working hypothesis. Let's put it this way. So hence I find it very interesting in the STEMI setting. This was post-STEMI. Yeah. And it was very interesting because it was a patient that probably had a high IMR to start with no flow at some stage of the procedure. And we still, after 3 weeks after the initial event, when we did the measurement you just mentioned, still had a slightly elevated IMR. So we're learning, but I believe it is a useful tool, and I particularly find it useful to identify patients at higher risk during the acute STEMI phase. And I'm sure we'll learn much more about that now that it becomes available for research and practice. And we are also still in the learning phase, as you know, but what makes it so attractive that it is so simple. You just need to add aortic pressure, and then all the rest is done automatically. So no additional hassle, and data are available immediately. So that is something that we need to learn from as a next step in the QFR developments. And of course, look forward also to work with you on that. And certainly soon Pioneer 4 will start. Yes. And there you are also participating. So we look forward to many more QFR cases with you and with your team. And I certainly like to thank you very much for this description of the case and your participation in the EuroPCR with this case. I think I found it very, very interesting to watch it also. So with this, I would like to thank you very much, Andreas, and look forward to next meetings. Thank you, Hans. Thanks for having me.
Thank you. Bye-bye.
Bye.